All right, let's talk about bleeding disorders. So these clotting disorders can be characterized in, I guess, three different camps. Those that have a deficient coagulation cascade, those that have a deficient platelet, and those that have some combination of the two. So let's start with the coagulation. So really, this is just hemophilia and vitamin K. Von Willebrand factor kind of belongs here, but this really is the last category. This is mixed. So hemophilia, really we have A and B. To some extent C, but that one's not really important. So I think of A for 8, and then B comes after A, and what comes after 8? 9. So hemophilia A is for A, and A is for 8 and B is for 9. Because this is a coagulation issue, remember that platelets has to do with superficial things like nosebleeds and mucosal bleeds and cuts. But if you're talking about joint bleeds, you're dealing with a coagulation thing. So hemophilia will be joint bleeds. Something called desmopressin, randomly vasopressin mimic, is going to increase the von Willebrand factor and factor 8, which obviously will help for hemophilia A. Aminocaproic acid. So this is an anti-fibrolytic drug. So this is going to inhibit plasmin, which effectively just means that whatever clots you do have are going to last you a little bit longer. So this is going to kind of help compensate for the lack of intrinsic pathway. We can also go ahead and just plug in frozen plasma containing factors. So frozen plasma has lots of coagulation factors, not just 8 and 9, but this would help for both hemophilia A and hemophilia B. So there's the difference between a deficiency of factor 8 and a factor 8 antibody, which people occasionally can develop. So how would we differentiate this, right? Somebody walks in and they have all of these joint bleeds. I don't know if they have hemophilia A or if they have just antibodies to factor 8. So the way a mixing study works, it really depends on two important criteria. So one is realizing that only a little bit of antibody goes a long way. So just a little bit of antibody will significantly prolong the PTT. On the other hand, you don't really need, so the second point is they don't really need that many clotting factors to maintain a normal PTT. So what's going to happen is this might be my patient. So let's say the truth is that my patient has an inhibitor. They have the antibody. We mix their serum with normal serum, and the inhibitors, the little triangles, these are going to still be there. And like we said, you only need a tiny amount, a small amount of an inhibitor to inhibit everything. So this will prolong the PTT. On the other hand, let's say that the issue is that someone has hemophilia. So now they don't have any inhibitors, but just notice there's nothing there. They don't have the factor A. Now you mix this with the normal serum, and well, it's 50%. And our point is you only need 50% to be normal. And in reality, it's not actually that they'll have 0. They might have some. And so it's probably going to be a little bit higher than 50%. But nevertheless, you get the picture. Vitamin K deficiency, again, think of K for coagulation. Again, we said that vitamin K is needed to, it's a gamma glutamate carboxylate. And it's just necessary to produce, to activate several of the coagulation factors. Now, it affects many of them, but it's going to affect 7 the most. And that's because it has to do with the production of clotting factors. And because factor 7 is the shortest half-life, this will be the one that is first and most dramatically affected by a production inhibitor. So what could cause a deficiency of vitamin K? Well, obviously warfarin, which is inhibiting vitamin K via epoxide reductase, but also antibiotics. Antibiotics are producing a lot of our vitamin K. Newborns often just have issues with their bacteria, so that's also kind of the same thing. Their bacteria are not producing vitamin K. And maybe you have a really bad diet, but it also could be that you have celiacs, you have some absorption issues, maybe you have a gallbladder dysfunction. Remember that A, D, E, K are all fat soluble, so we might need bile to help this be properly absorbed. And note here that yes, it is getting coagulation factors, but it's also affecting protein C and protein S. So it also is necessary for some of your coagulation inhibitors, which will come back very soon. That's going to be important. So other ways we can get clotting deficiencies is through transfusion. So if we give somebody saline or IV fluids, these don't have clotting factors, so this will just dilute the plasma and basically make the clotting factors at a lower concentration. Alternatively, if you do a blood transfusion, this is also no clotting factors, it's just red blood cells and platelets. So the treatment for this is just give somebody fresh frozen plasma. This is going to have the clotting factors. We were just talking about this with hemophilia. This is going this is, if you give someone FFP, this is just giving them coagulation factors. Another component, kind of the other side of FFP, is cryoprecipitate, which is specifically fibrinogen. Cirrhosis-induced clotting deficiency. Remember that for pretty much everything except, factor VIII, the liver is going to produce is going to be like a central player. So if you have cirrhosis, you can't produce a lot of your clotting factors. Because, again, 7 is the shortest half-life, the PT or the INR, which is just the normalized ratio of the PT, is going to be the most significantly affected. Also keep in mind that the liver makes thrombopoietin, which is necessary for megakaryocyte and platelet production. Also, if you have cirrhosis, you might develop portal hypertension. And so you're going to have this buildup of blood that's going to effectively push this blood flow back into the spleen. If you push more blood back into the spleen in the venous system, the spleen is just going to eat up and destroy more platelets. So not only are you producing less platelets if you have cirrhosis, you might be eating up more platelets because you're redirecting more blood flow over to the spleen. So that was coagulation disorders. So now looking at platelet disorders. So Bernard, I'm not sure how to pronounce this, Soulier, a GP1 receptor. Remember that this is chronological. The GP receptors are the platelets. This is going to be necessary for adherence to the subendothelium via the von Willebrand factor. Randomly makes the platelets really large. So look at these tiny things. These are platelets over here, and this is a huge platelet, almost as big as the red blood cell. And just to really emphasize this, all of the bleeding time should be up for the platelet disorders. Why? Because they're platelet disorders. The bleed time specifically just looks at superficial cut bleed times. So every single one of these, if I don't say it, just the blood time goes up. Glanzmann thrombosthenia. This is going to be GP2 and GP3. So remember, GP1 is for the adherence to the subendothelium. GP2 and GP3 are for platelets adhering to other platelets. They don't adhere directly. They adhere through fibrinogen, sometimes von Willebrand factor. Wiskott-Aldrich syndrome. So this is the WAS gene. The WAS gene is necessary for the actin cytoskeleton to function. We saw this with the immune system module. This causes the leukocytes and, again, like I said, they can't reorganize their cytoskeleton, which has various effects. Low platelet count and dysfunction. Also, the MHC and the antigen presentation doesn't work, and it causes eczema. So that's kind of a weird assembly of symptoms. That one's probably not particularly important. Much more important is idiopathic thrombocytopenic purpura. So we mentioned in the very first intro to clotting that petechia and purpura are specifically going to be superficial skin blood bleeds. We're going to see this in platelet disorders specifically. So this is idiopathic. So this is a diagnosis of exclusion for the most part. So it's thrombocytopenic, which just means you have a low platelet count. Often this is because, so it's idiopathic, but sometimes, let's just say 50% of the time, it might be because we have anti-GP2 or GP3 antibodies. So if we go ahead and tag these GP2, GP3 antibodies, usually when you have something tagged by an antibody, that just makes it so that the spleen can eat it up much more effectively. And if the spleen is eating a lot of these antibody-tagged platelets, it's going to cause splenomegaly. Treatments would be just, let's depress the immune system with steroids. You can flood somebody with IVIG, which really just means we're flooding with Ig antibodies, which will compete for the macrophages' attention in the spleen. So rather than the spleen binding to the platelet autoantibody, it'll bind to one of these antibodies. It's just a competitive inhibitor, so you're just going to have less platelet consumption. You can also just take out the spleen in refractory cases where they're not responding to steroids or IVIG. So quick word on what happens if we take the spleen out. So the bone marrow sometimes puts out red blood cells with the nucleus still in it. These are called Howell-Jolly bodies, so this is one here. Now, the bone marrow might put it out accidentally, but you know what? The spleen's really good at catching these and gobbling them up. But if we take somebody's spleen out, maybe to deal with, particularly bad ITP, the bone marrow will put these out and we can't get rid of them. So we're going to see more Howell-Jolly bodies. So similar thing is instead of ITP, we now have TTP, and the T here, I for idiopathic, but here thrombotic. The one before wasn't thrombotic; it was just thrombocytopenia, meaning we had decreased platelets. But now we're also causing a thrombus on top of everything. So why are we getting a thrombus? So we have something called ADAM TS13. So it turns out that von Willebrand factor. So this gets destroyed to an autoantibody. So von Willebrand factor is typically stored as a multiper in the Weibel-Palade bodies, in the endothelial cells, and the alpha granules, and the platelets. But when it's released into the blood, ideally, so here we have it being all stuck together. ADAM TS13 is supposed to, you can see it's kind of broken up here, it's kind of broken up there. Breaking it up causes it to not aggregate so much, which means things can spread out a little bit. However, if we have these antibodies, and sometimes the antibodies might be precipitated by clopidogrel, which is a medication we'll talk about soon. Now we can't break it up, and we see that we get this huge aggregation, and this is just a thrombus. These thrombi are going to be in small vessels. This is a syndrome called MAHA, which we'll talk about in the next slide. A couple of, I think of T for trio. You get this interesting trio of symptoms. You get a fever, renal failure, and neurological symptoms. Those are big ones to look out for. Not a lot of neurological symptoms on this exam. So if you see that, you might think TTP. Okay, so what is MAHA? So whenever we have a thrombus of a small, basically like a capillary, this is going to be MAHA. Notice that it is a micro, so that's the small blood vessel, and then hemolytic anemia because the red blood cells are going to break. So if this is let's say our blood, that's an endothelial cell and that's an endothelial cell. This red blood cell does not have a lot of room to get by. And so it cleaves against the sharpness of this platelet here and it becomes a schistocyte. So it's trying to squeeze by and it cuts off like a third of itself. And you can see these here, you can see another one there, you can see another one there. So these are schistocytes, which are just sheared red blood vessels when they're trying to go through capillaries. And anytime you have a hemolytic anemia, you have a red blood cell breaking open. Lactate dehydrogenase is going to spill out. Remember that is red blood cells do anaerobic fermentation. So they have a lot of LDH, not many things do in our body. And then haptoglobin, whenever we spill hemoglobin into the bloodstream, haptoglobin is going to bind to it and stabilize it. So that means if haptoglobin is too busy binding on a hemoglobin, the free concentration of haptoglobin is going to go down. And so this is just kind of a better picture. Here's our little thrombus and our small blood vessel, and this is trying to get by. Oops, it bumps into it, it gets a little crack, and now we have our schistocyte. So TTP was just our introduction there, but hemolytic uremic syndrome and DIC, disseminated intravascular coagulation, also are going to cause this. So anytime you see the schistocytes, think one of these three syndromes, all of which have to do with platelets. So HUS, very similar to TTP, no fever, no neurological symptoms, but the kidney is still a thing. And again, we just mentioned this, but you're also going to have MAHA. You're going to have a capillary thrombus. Now, this is precipitated by E. coli toxins. I think that's important to know. So DIC, of all of these, DIC might be the most important to clot or not to clot. And it turns out it's doing both. You have clotting in one part of the body, and because there's so much clotting in one part of the body, it's actually consuming the systemic coagulation factors. So in the next part of the body, you actually cannot do clotting. So it's both. Fun, this is a wall of text. So disseminated, just meaning that it's spread throughout the body. Intravascular, because it's within blood vessels. And I actually don't like to think of it as coagulation, although the term is intravascular coagulation. I think of it as clotting, because clotting kind of encompasses primary and secondary hemostasis, platelets, and coagulation. So this consumes a lot of clotting factors. So one part of your body robs the other part of your body of the necessary factors. So we might have clotting in region X, which means we cannot do clotting in region Y and Z because we lack necessary factor 10 or necessary thrombin or necessary factor 7, etc. The clots typically form in microthrombi, meaning MAHA, meaning we have schistocytes. Now, what can cause DIC? Obstetric emergencies, because the amniotic fluid has tissue factor, sepsis, the toxins and cytokines, kind of like we saw with HUS, the E. coli toxins. These can activate coagulation factors, leukemia. We'll see this when we talk about Virchow's triad. Various types of cancers can produce molecules which are pro-coagulation. Rattlesnakes, randomly, their venom can precipitate coagulation. It can activate coagulation factors. And because we're consuming all of our coagulation factors, all of our platelets, pretty much all of these tests are going to be abnormal. All of our times are going to be higher. It's going to take longer to clot. We're going to have lower platelets because we're consuming them in region X. Fibrinogen is going to be all used up. And we're going to have anemia because we're destroying a lot of our red blood cells in the microvasculature. And so we're going to have schistocytes and elevated D-dimers because it is true that, yes, we're using up a lot of our clotting factors. So we saw all of this. But nevertheless, in region X, we had a ton of clotting, and eventually that clot's going to be broken down, and that's going to give us a lot of D-dimers. So the treatment would be fresh frozen plasma to replenish the clotting factors, the red blood cells, because we had the shearing, the generation of schistocytes in the microvasculature and the MAHA, the platelets, because we said it's not coagulation, it's clotting. We're using up a lot of our platelets as well. And then we also want to replenish the fibrinogen. So we're going to go ahead and provide cryoprecipitate. So just a little summary of all of this. So ITP, TTP, and HUS. So first of all of these have to do with platelets. All of these are consuming platelets. The platelet count should go down for all of this. Now the MAHA. Remember the MAHA, this is just the thrombi in the microvasculature. This was only for TTP, HUS, and DIC. And so we have... now, if we're just looking at these two, remember that this was just we have the thrombus, which is why we're getting the schistocytes here and here, the hemolytic anemia, which is just that schistocyte is just the evidence of hemolytic anemia. But this is just with a platelet. Now in DIC, remember I like to say it's not coagulation, it's clotting, it's platelets and fibrin. So that means that we're consuming the coagulation factors exclusively in the DIC and not the other ones. That's why the PT and PTT and I guess INR are going to be elevated in the DIC specifically. And now just to differentiate these two, both of them are going to have kidney issues, but you have fever and confusion. Remember T for triad, the fever, confusion, and kidney issues. But the HUS, this is the E. coli GI illness, and this is just going to be kidney issues. Von Willebrand disease, so this is going to be kind of in both camps. This is both coagulation and this is platelets, primary and secondary hemostasis. So this is a very common bleeding disorder. To test for this, we can provide ristocetin. So ristocetin should bind von Willebrand factor. So here we have a normal individual. We add ristocetin and it binds von Willebrand factor, which kind of causes the platelets to aggregate together. However, if you are von Willebrand deficient in this bottom picture, when you add this, it doesn't really do anything, and I don't have any aggregation. So like we saw earlier, desmopressin randomly mimics vasopressin. Well, maybe that's not random, but what's random is that it increases von Willebrand factor and factor VIII. Other causes, chemotherapy and leukemia can destroy the bone marrow, which means we have less megakaryocytes and we have less platelet production, cirrhosis and portal hypertension. Remember, the liver is going to go ahead and generate all of the clotting factors except for factor VIII, which is made in endothelial cells. And so the clotting is going to go down. Now, that's coagulation. Now, let's talk about the platelets. We talked about this earlier, that if you have portal hypertension, you're going to redirect blood flow to the spleen, which causes the spleen to destroy the platelets. The liver's job is also to make thrombopoietin, which causes the megakaryocytes to be produced. So you're going to have less of that, less platelet production. A normal platelet count, just FYI, should be around 200 to 400,000 per milliliter. Not to be confused with, and I think very important to know, which is why I mentioned here, the 5, 15, 45, the rule of 3. So red blood cells should be at about 5 million per microliter in the vasculature. Looking at hemoglobin should be 15 grams per deciliter, and the hematocrit should be about 45%. So 5 times 3 is 15, 15 times 3 is 45. All of these are more or less normal values, which is separate from, but not necessarily more important, knowing the platelet count, which should be about 200 to 400,000.